Hi, this is Dr. Mora. I'm an orthopedic surgeon here at Restore Orthopedics and Spine Center. I'm super excited today to be able to record Dr. Jermanovich. He's my colleague here at Restore. He's an interventional pain management physician. His expertise is in helping people with chronic pain. More notably is helping people get off narcotics. I've seen him work here. I've seen his patients, I've seen his results, and this is why this is very exciting to me, being able to be part of this discussion here today. We will be talking about the opioid epidemic, and we will be talking about how he treats patients, but I'm going to tell you something that I feel strongly about. Dr. Jermanovich saves people's lives, okay? He is not a pain management physician that is writing prescriptions for patients so that they can worsen and so that they can treat their pain with more OxyContin. On the contrary, his goal is to help people with their pain through other means, whether it's holistic, whether it's interventional, that means injections, whether it's with chiropractic treatment, rehabilitation, psychological treatment, whatever it is, it's focused on making their pain better, but also keeping them away from deadly narcotics. Why do I say deadly? Because in 2017, Centers for Disease Control estimated that over 47,000 Americans died due to opioids. So what are opioids? Heroin, synthetic heroin such as fentanyl, or prescription medications, especially like OxyContin, Percocet, Vicodin, things like that. 47,000 people, that's approximately 130 per day. 130 people per day are dying from opioids. So that is why this topic is very important. It's very important that people understand that these drugs kill. It's important that people understand that the prescription medications that we have traditionally prescribed for patients with pain lead to other drugs, such as the illicit street drugs. And it's really important for people to know that that's not the solution for their pain. There are alternatives. But once again, this is really exciting. We're going to be recording here in a second. I'm going to have Dr. Jermanovich come over here and discuss how opioids affect our mind, how opioids lead to death, and then he's going to briefly discuss what he can do to help people that have a problem with pain. So with no further ado, here's Dr. Jermanovich. And I'm looking forward to seeing what he says. Thank you very much.
Hi, I'm Dr. Jermanovich. I'm here working at Restore as an interventional pain physician. And today we'll have a discussion about opioids. And Dr. Mora wanted to ask me a question. Go ahead, Dr. Mora.
So this is the thing, Andrew. You know, a lot of us physicians prescribe opioids for our patients. We really mean well. I mean, I'd say that the majority of physicians mean well when they prescribe their patients opioids. So now that it's become apparent that opioids can actually kill people, and this huge marketing push by drug companies has now become obvious that the information that presented to us in the 1990s was erroneous. So now we're realizing that maybe we weren't doing the right thing. So why don't you please explain to us how it is that opioids are killing people?
So it's important to understand the mechanism, and my job as a physician when I have a discussion with opioid ingesting or opioid taking patients, whether they're taking it on a chronic basis for chronic pain or they're taking it for a very short period of time for post-operative acute pain. The discussion I have is that each patient should be empowered to understand how opioids work. And so I like to draw for a lot of my patients, and I would also like to draw here for the audience. So the way opioids work is that they bind to certain structures in a central nervous system. What's a central nervous system? Central nervous system is simply brain, okay, which looks like a boxing glove, and a spinal cord. And so all pain, regardless of its origin, starts somewhere in the periphery, say for example in a foot. It starts somewhere in the knee after a knee replacement, or it's somewhere in the spine. all pain is generated as a chemical signal that is then converted into an electrical signal that goes up in one direction toward a spinal cord, and then it hitches on into an information superhighway that carries this pain signal to the surface of the brain, an area we call sensory cortex. Okay? So before the pain gets there, it can be modified. It can be changed. And the spinal cord is great at modifying the pain signal that's transmitted over there. Opioids work by binding to a small little antenna. Let's say, draw a little letter M. And imagine this is a little satellite dish that receives a signal. The name of this antenna on the surface of the spinal cord is called a receptor. So it receives a signal. And the way an opioid works is that it binds, say this is an oxycodone molecule, it goes and binds to this receptor and it produces an effect. What kind of an effect? I told you earlier that all pain information goes up the spinal cord in one direction, and that is toward the brain. And so say we have a certain number of beeps of signal traveling in this direction toward the sensory cortex, which is where you ultimately feel pain. And pain signal is going up this way, and when you have an opioid molecule binding to the opioid receptor, there is a mechanism employed that causes decrease or inhibition of a pain signal. Okay, so we shut down transmission of signal traveling up toward the sensory cortex of the spinal cord. Your body likes this, and it says, your spinal cord says to you, say, hey, this is great, can I have another? And so what you have is generation of new receptors, but your body modifies them. So you build up tolerance, and tolerance is your body's way of building up resistance towards an effect of a drug. And so these receptors that come back on the surface are less functional. So it takes 3 times as much drug to get the same level of pain relief as you initially received when you took Norco, oxycodone, morphine for the very first time and you obtained great pain relief. This is a problem. The reason this is a problem is because the pain signal that goes up is not the only electrical signal that is important in our body. There is another important signal that is originated in this part of the brain, and this part of the brain is called midbrain. And in the midbrain we have a structure called medulla. Okay, medulla. And medulla generates a rhythmic signal that produces breathing. And it produces this signal in a small little box, okay? And this box gives away an electrical signal in the opposite direction. And this signal travels via 2 nerves called phrenic nerves, phrenic nerves. And these 2 nerves have one job, and that is to operate a pump. And the name of that pump is the diaphragm. It goes up and down. When my diaphragm in my stomach goes down, air goes in because a negative pressure is created, and that's how ventilation or breathing happens. Unlike a signal that goes up, an electrical signal that goes up to the surface of the brain, this is a signal that goes up in the opposite direction. It goes that way. And just like we have opioid receptors on the surface of the spinal cord, we also have opioid receptors in the midbrain, and also in a small respiratory center of medulla. And the opioid doesn't discriminate between which receptor it binds to and turns off a signal. It turns off a pain signal that goes up just as well as it turns off a just as well as it turns off a respiratory signal that goes in the opposite direction. And so the scenario is typically as follows. A pain patient who hasn't slept in days because of pain, who is depressed about their pain, who has anxiety about their pain, takes a medication for pain like an opioid, which binds here to relieve pain, but also binds at the midbrain to shut down the drive to breathe. Also takes a sleeping medication prescribed by a psychiatrist or their primary care physician that also, through a different mechanism, binds to this respiratory center to blunt your drive to breathe when you're most vulnerable, which is in the middle of the night or when you're asleep. People also take various anxiety medications from a class of drug called tranquilizers, also known as benzodiazepines. Guess what? Benzodiazepines also have very different receptors, and again, they suppress your drive to breathe when you're most vulnerable, which is during sleep. So here's a problem. You take a benzodiazepine or a tranquilizer because you're anxious. You take an opioid because you're in pain. You haven't slept in days, so you take a sleeping pill. Okay, so say we take an Ambien. And this is a triple cocktail that works together on this one area to shut down one's drive to breathe. And typically, the death from opioids is when patients are most vulnerable and there is no one to wake them up because everybody assumes they're sleeping. So the 19,600 patients last year who were patients who received medications from their physicians died in their sleep while taking these medications prescribed by their doctors exactly like the label said.
So can you also explain how alcohol affects that area? Because sometimes what can happen is a patient doesn't, instead of taking an Ambien for sleep, maybe they'll have 2 big goblets of wine or maybe a couple of shots of tequila or whiskey, and that seems to also exacerbate this effect here. Is that correct?
Alcohol, absolutely. Alcohol is a drug which is very similar in its function to benzodiazepines or tranquilizers. In fact, they work on a similar group of receptors called GABA receptors. And it also blunts one's response or sensitivity to a breathing signal. So it blunts the respiratory drive in addition to opioids, in addition to the benzodiazepines, and in addition to hypnotics or sleep medications. So the question is, what do we do now? I mean, we have a serious problem. We have multiplied these receptors that don't work well. So a pain patient now finds himself between a rock and a hard place in the sense that they need a massive dose of opioids because of tolerance, and at the same time, the problem has not gone away because the generator of pain continues to be their spine, continues to be their knee, continues to be other part of the body. So the question is, what do I do as a physician? And that's what sets me apart, because I understand the mechanisms of how this is generated and also medications that combat or fight against this mechanism. So I told you earlier that the pain signal that is generated by spine, knee, and foot can be modified when it goes up to the sensory cortex. And so there's an area in the spine that is called a wind-up area, wind up like wind, wind up. And what it does is that it amplifies pain signals. So for example, you have a spine pain that is 5 out of 10 on average, and then this spine pain persists every single day. And so your body adapts to this, and it wants to really, for you to pay attention to this pain. So it takes this 5 out of 10, which goes to this area, and it amplifies it, and when it goes to the brain, it really becomes a 10 out of 10 pain. This is called central sensitization, and opioids make this mechanism worse. This mechanism requires a use of a particular receptor called NMDA. NMDA, which stands for N-methyl D-aspartate receptor. It's a particular type of receptor, but this receptor is notorious for amplifying a pain signal, and those people who chase pain relief with opioids inadvertently end up dead because their physicians do not understand their mechanism. What do? My priority when I get a patient on opioids is that I need to strip their spinal cord of all these extra receptors that they grew. The reason is these receptors are dysfunctional. They don't work properly. And so I need to also address the source of their pain, which is a pain generator. So through various techniques that I employ, which is injections that may or may not involve killing or burning of nerves that aren't useful anymore in a chronic pain scenario, I target the area of pain, try to kill the source of the pain. Then I employ a strategy to try to decrease the number of dysfunctional opioid receptors that have grown on a spinal cord. And I use one drug and one drug in particular, and sometimes another. And this drug, when I pronounce or utter that drug to other people, they gasp in disgust because everyone has heard about it. The name of that drug is methadone. Now, I use methadone, but now I'm not in addiction medicine. I'm not an addiction doctor. Why do I use methadone? And the reason I use methadone is because this is the only opioid that shuts down this receptor. And when it shuts down this receptor, it shuts down the mechanism of wind-up. So patients who have amplified pain, pain that is not real, pain that is 10 out of 10, whereas the generator only generates pain that's 5 out of 10, when they go on this drug, their need for opioids decreases substantially. And the longer they stay on it, the lower the dose that they can be on over time. And so once I've gotten them out of a habit of taking opioids on an as-needed basis, take away control from them, and give them methadone, a drug that lasts 8 hours that they take on a scheduled basis 3 times a day, and I've addressed this mechanism, and I start killing off all these extra receptors that they have grown through this NMDA mechanism, what I find is their need for opioids diminishes substantially. And then, as I'm targeting the sources of pain by doing interventional pain treatment techniques, I will slowly get them off the methadone as well. This is a temporary measure. This is a temporary transition period that I need to control their pain, to shut down this wind-up, and also to prevent them from self-medicating and avoiding this accidental overdose from opioids, benzodiazepines, and hypnotics. So what other drug is there? The other drug is expensive, and that is the issue with it. The other drug is called ketamine. Ketamine. This drug also targets this very same receptor, but for the most part can only be used as an infusion for it to be effective. And infusions are expensive because it's an IV, and these patients typically have to be monitored by a nerve or myself because of the complications of this drug and side effects. So, you've asked me, how do I get my patients off the opioids? Number one, I have to address the source of their pain. I do it with various techniques. I do it with different medication classes that, understanding all this, do not interact with opioids acting at the medulla and don't shut down or contribute to shutting down of the respiratory drive. Once I achieve that, I slowly taper the methadone dose to the lowest effective dose. And once the source or the generator of pain has been dealt with, then I taper the methadone, I get them off of it entirely, and I give people or my patients their life back.
That makes a lot of sense. I think, you know, a lot of people do know about respiratory suppression, which can happen, but I think what they don't know is basically this mechanism that you're discussing. I think this is a great approach to treating, to treating pain. So, can you recommend anything to a patient that might be watching this, or maybe a family member who has a loved one, to maybe move in the right direction? Like what can be a first step for people to get them going in the right direction?
Always a visit with a pain specialist. There are many specialists in this field, and what sets apart a pain specialist from other physicians, like an anesthesiologist, is that what we study a lot, more than any other specialty in medicine, is drugs and how they work. Because as an anesthesiologist, my job is to wake up a patient from a coma. If I do not understand how this drug works, patient will not wake up. So I have to understand the tiniest ramifications of these medications, how they interact with all other medication classes, And my deep and detailed knowledge of medications is what sets me apart as a pain management physician. And so a lot of physicians have a prescription pad, and they'll say, you know, I have the same prescription pad as you do. I can write most of these medications. But it's understanding of how these medications work and explaining that to the patient that really sets me apart from other physicians from different specialties. And so I'm not saying I'm the only physician that can solve a lot of these problems. Every board-certified pain management physician can, but it's all about a comprehensive approach of targeting the source of the pain, targeting the areas in a spinal cord that amplify pain, making it useless. Chronic pain and acute pain are misunderstood among patients because, to me, pain has value. If I step on a razor on the floor, it produces a signal that may lead to injury, infection, and death. It's a useful signal. However, a chronic pain signal in an area that has healed or had been surgically altered, say like the spine, continues to generate pain, and oftentimes that pain moves centrally. Central pain has no value, and it torments people, and it feels as if the pain is real, and as if the injury in a spine has never gone away, despite the facts to the contrary. And so understanding pain is what pain specialists do well, and they also are trained in all these techniques to address the source of the pain, to deal with the medications and their side effects, and to have a comprehensive, big bird-eye view of the patient and all of their problems to be able to address them one by one. And so what I like to say often is a chronic pain patient is like a complex mathematical problem. So if you have a calculus problem, it looks horrible when you first look at it, but if you break it up into parts, you're able to solve it if you do it one by one. And that's how I approach a pain patient. So I take a patient, I look at them, I listen to them, I look at the whole history, look at all their medications, and then I offer them a solution. And so far, there hasn't been a single patient whom I was not able to help. I always find a way.
What would you say are red flags that a patient can look for when they are looking for a pain management specialist, but perhaps somebody that maybe should not be in charge, or maybe they should look for someone else? You mentioned that you're a board-certified anesthesiologist, pain management specialist, but you know, we hear in the news about these quote-unquote pain management doctors who get arrested. I mean, they're pain management doctors. That's what it shows on their business card. So can you give some patients some tips on some guidance on how to know if they're going to the right doctor?
Pain management doctor is typically a physician from one of three specialties, which is anesthesiology, physical medicine rehabilitation, and sometimes psychiatry or neurology. And these physicians undergo additional training through a fellowship. And fellowship, it may be a year, sometimes can be as long as 2 years. And during this period, these physicians do nothing but specialize in chronic pain and in-depth study of medications. Sometimes people from other specialties call themselves pain management. Chiropractors call themselves pain management because they say, I manage pain. Well, not chronic pain management, because that requires knowledge of multiple disciplines of medicine. I need to know psychiatry. I need to know neurology. I need to know physical medicine and rehabilitation. I need to know a little bit about orthopedics. I need to know a lot about anesthesiology and mechanisms of drugs. And that is what makes me a pain management physician. And I am able to help a patient because of my skill set, which is treating the source of pain, but also my knowledge of medications which are commonly prescribed. So other physicians, like family practice physicians, are also able to prescribe a lot of these medications, but they do that out of despair to help their patients because they believe that no help is available to them. And so they start these patients on opioids, and the statistics are that if you are on opioids for 35 days, your chance of addiction is 50%. That is a statistical fact. And so if you're on it for 2-3 months, the road back to recovery may be difficult. Majority of people who have started their path on prescription opioids end up on heroin if they're not addressed and properly treated, if they're dismissed from a practice for misbehavior or misdeeds. And so if I see a patient who comes in and their objective is to get a medication that is specific a specific type of opioid, for example, and they insist that they be prescribed this opioid because they're allergic to ibuprofen, they're allergic to gabapentin, nerve-modifying agents, I immediately suspect doctor shopping. And so I have tools available to me through the Department of Justice, through urine toxicology to verify their story. And so I am also a detective in a way that I'm able to discern between what is truly a chronic pain patient that is seeking help versus who is someone trying to obtain opioids for diversion or abuse or misuse. So I'm able to read people well, but I don't trust my own judgment. I rely on tools available to me provided by the government to weed out people who pretend to be patients but really are there to obtain opioids for illicit use.
Thank you. Thank you for addressing that fact about being on a prescription medication such as Vicodin and how that could easily lead to an addiction. So one more question. If you could give a tip to a physician like myself, an orthopedic surgeon, or someone else that treats musculoskeletal problems acutely, such as for after surgery, we give them some medication. What would you recommend that we do, a person like myself, to help patients so that they don't get on a course that will lead to death? Like, what could you say to me right now to help me with my next total knee replacement patient that will actually help the patient as well as help me?
I think nothing substitutes proper planning. We can create a lot of pain. We don't know a lot of the patients we deal with. A lot of them tolerate pain very differently. And so I firmly believe that a consultation with a pain management physician preoperatively for perioperative pain control, meaning before, during, and after surgery, would be absolutely optimal. And so as an anesthesiologist, I am familiar with blocks, although I don't do them in our surgery center. I understand their utility and prescription. So when the patient comes to me, I evaluate and look at their medication regimen, I change it appropriately, and I prescribe them medications for post-operative pain. I manage them from beginning to end, and when they are given an opioid prescription, it is brief, it is short, it is for a short period of time, and they are requested to return and see me for a follow-up visit shortly after surgery, typically a week, maximum 2 weeks out if they're unable to ambulate or move well after surgery. So, but if you did not have a relationship with a pain management physician, or you couldn't get a patient in a timely fashion for a preoperative consultation, it's also wise to give a patient a short prescription for opioids, maximum a week, and give them frequent follow-ups if you do not have a relationship with a pain management physician in the neighborhood. That way, that you can really assess their continued need for these dangerous medications and see if you can switch them to classes of weaker opioids or multi-mechanistic drugs like tramadol that has other mechanisms by which it reduces one's pain, and adding medications from different classes, for example, gabapentin before and after surgery to reduce the inflammatory small fiber nerve pain.
Thank you very much. Actually, I do have one last question. If you were to name one prescription medication that you feel is maybe the most lethal, or the one that might lead to someone getting on this terrible path that leads to addiction and death, which prescription medication would you say is one of the worst that a person like myself can prescribe a patient?
Percocet, hands down. Absolutely no argument about this medication. This medication single-handedly created opioid epidemic in the United States. And the company that did so was Purdue Pharma, the creator of OxyContin, who hired armies of company representatives or sales representatives who went to doctors' offices and tried to convince them from fabricated data that this class of opioids in a delayed release formulation was not addicting simply because it was put or placed in a pill that trickled out medication over time. This was a fallacy. This medication has been around since World War II. The Germans have created it, and they were horrified with what they saw. This medication causes intense analgesia because it's so highly specific for this very receptor. It binds very tightly to this receptor, and it's also highly bioavailable. Bioavailable means this: if I take 100 milligrams of a drug, 70 milligrams will be in a bloodstream, and the intestine will dump the rest of it. Oxycodone is one of the most bioavailable medications, meaning that it has very good penetration from intestine into the bloodstream, and when it penetrates the spinal cord, it produces an intense analgesic or pain relieving effect, but at the same time produces intense euphoria. I think opioid epidemic in the US has been created mostly by the Percocet, and it's typically a short-acting version of it, like Percocet or short-acting oxycodone, but hydrocodone, also known as Norco or Vicodin, has also been part of the problem, and I avoid prescribing these short-acting medications at all costs in chronic pain, and I believe their utility is only in post-surgical acute pain and only for short periods of time, 1 to 2 weeks maximum, and these patients should be seen by a pain management physician if their pain continues or persists.
Great, thank you so much. Super helpful information, even for an orthopedic like myself. Truly appreciate the time that you spent explaining the mechanism here. I think a lot of people are going to be helped by this. So thank you so much, Dr. Jovanovic.
Thank you very much.
Cheers.
Thank you.